We talk about the location. Generally, location is for the abdominal aortic aneurysms. We commonest one is the infrarenal one. So this one, which is below the renal arteries, and and between the renal arteries and the aneurysm, there is a normal area. Okay, so this is the infrarenal. So if the normal area is there, it's infrarenal, and if it is just below, without any normal region, that's juxtarenal. Pararenal is if the arteries take off from the aorta like this, but the SMA, superior mesenteric artery, is not involved. These arteries are clear. And if all of it is involved, this is a suprarenal aortic aneurysm. That means any one or more arteries, more than one visceral artery is taking off from the aneurysm, but it's just below the chest, going up to the chest. So this is how we categorize it, as commonly as infrarenal, juxtarenal, pararenal, or suprarenal. So just a bit of imaging, not my forte, and obviously we do not need. This is a bit of a specialized thing, but the recommendation we should know that that imaging and measurement are an important component of diagnosing not just the presence of an aneurysm, but what is the risk of rupture and what is the need for surgery, if any. Okay, so the recommendations, the green ones are the grade 1 recommendation, which is a strong proof and strong supportive evidence in clinical publication and that recommend these conditions. So mostly aortic diameters have to be measured in landmarks which are reproducible and a cross-sectional area perpendicular to the flow. Okay. If it is oblong, then the longest diameter is used as the direction of flow, and we measure in a perpendicular fashion to that longest axis. Okay. When we are using CT or MRI imaging, I'll just be giving through brief on all of this. We measure inner to inner, unless there is atherosclerosis. So we are measuring from the inner diameter to the inner lining to the opposing inner lining. So whether it's the root, the sphenotubular region, this is the mid ascending, distal ascending, aortic arch, proximal descending, and mid descending aorta. Okay. So these are the various ways that we tend to the guidelines which recommend measurement using any of these modalities. Okay. Now the question arises that which of the modalities are helpful. All of them, they have their pros and cons. Availability, nowadays everything is available, especially in the metros. Even MRIs are present, but not all of them are portable. So if you need to do anything on the bedside, either it's an ultrasound or a transthoracic or a transesophageal echocardiography. CT are the fastest in acquiring an image, followed by transthoracic or echoes or ultrasounds. Okay, resolutions of CT and T are the best. The three-dimensional setup, obviously CT gives you the best three-dimensional view, and what is the branch evaluation, but valves need to be seen in real time with flow determinants. That's why if you want to see the valvular function and the ejection fraction, a transthoracic or a transechocardiography, transthoracic and transesophageal echocardiography give you the best results. Okay, what are the essential elements? If we ever tend to watch closely what the results show like, we should know that at whatever level we are talking about, what is the maximum aortic diameter, because that determines whether the surgery needs to be done or conservative management needs to be done. Okay. If there are abnormalities, they need to be determined whether the wall is thickened, there is a thrombus, there is atherosclerosis. If there is stenosis, any occlusion that needs to be described. What is the extension of the syndrome, whether any dissection or tear is there, what are the branches involved, what type of a disease that we feel might be there, or the cause of the disease, if it is feasible or visible in the report that is being created. Okay. So as we discussed in a couple of slides back, surveillance is the major reason of or major factor which leads to diagnosis of diseases, because as like atherosclerosis and diabetes, this and cerebral malignancy, it is a silent disease. So if we have diagnosed a patient and we know that the size maximum diameter is less than 4 centimeter, we can go for a third yearly imaging. If in men, it's, as we know, men are more predisposed. If it's up to 5 centimeter in men or 4.4 in centimeter, and yearly imaging needs to be recommended. Okay. If it is more than 5 centimeters in men and more than 4.5 centimeters in women, we go for a 6 monthly imaging, because that is the category where chances of rupture are the maximum. Where the background of the causes, the pathophysiology, the classifications, and the imaging modalities that are recommended. With that background, we talk about the management. We should keep one thing in mind, that medical management is a very, not that an optimal line of treatment of this patient. More so, it's surgical management. If the patient is optimized for surgery or is able to go through surgery, mostly if the patients are non-operative or small aneurysms are present, that is the case where medical management comes. No specific guidelines talk about medical management, especially about the aortic and abdominal aneurysms. We have suggestions for cessation of smoking, but that is for all the other causes apart from aneurysm. That is for coronary artery disease, peripheral vascular disease. But yes, aneurysm-related mortality might be less if smoking is ceased in a patient. Okay, general cardiovascular risk reduction with statins is suggested, especially simvastatin, antiplatelet low dose aspirin therapy for overall cardiovascular risk and decrease in overall cardiovascular risk is there. Uh, if you're talking about treating the hypertension, ACE inhibitors are associated with a better outcome, decreased chance of rupture. Beta blockers are inconclusive, but calcium channel blockers don't seem to be helpful for managing hypertension. So ACE inhibitors are generally our base of treating patients who are hypertensive with an aneurysm in the background. Certain new therapies, future therapies of antibiotics and metformin have shown promise, but they are not the norm right now.